Now, we're going to look at a different case here. Hopefully I can get finished in time. This is a nodule on the foot of an elderly adult man. And you can see it's a multinodular cellular proliferation filling the dermis and probably pushing down into the subcutis and kind of replacing everything. It's a multinodular hypercellular. And when we go closer, we can see that the cells are mostly spindled, maybe spindled, plump spindle cells, or even a bit of epithelioid cells in some areas. And they're kind of arranged in vague streaming fascicles that intersect here. They are atypical, but not dramatically pleomorphic, I would argue. They kind of are somewhat monotonous, but I think they're hyperchromatic, they're enlarged. So to my eye, they seem kind of atypical. As you look around, I don't know where, but there are mitoses in here. They're not numerous, but they're easy to find if you look for them. There's one right here. Here's another right there. So there are relatively abundant mitotic figures. Okay, maybe I haven't looked at this slide carefully. They are kind of numerous. I'm seeing mitoses, quite a few of them now that I look more closely. It's been a while since I looked at this slide in detail. It's from long ago. But I might be struggling, where do I put this? I mean, spindle cell melanoma, spindle cell carcinoma, maybe. You could run the kind of immunostain panel for the kinds of tumors we might see in the face or sun-damaged head and neck of an old adult patient. But this is on the foot. You know, if you did stains, it would be negative for S100, probably negative for keratin, negative for desmin, negative for actin. So then you would left with, well, what is this? Is this atypical fibroxanthoma or pleomorphic dermal sarcoma arising on the foot? That would be very unusual. Well, let me show you another example of this same entity that has kind of similarities with this, but one feature that this case is missing. And then I think the diagnosis will be very apparent to you. It's a nodule, hypercellular, in acral skin, on the foot probably. We go closer, it's made of spindle cells arranged in streaming fascicles. But what do we have here that the other case was lacking? Red blood cells. There are erythrocytes filling slit-like spaces between the spindled tumor cells. And once you see spindled cells in fascicles with extravasated erythrocytes, the first thing that probably comes to your mind is Kaposi sarcoma, because that's what this is. This is nodular stage or tumoral Kaposi sarcoma. And that's what this case is also. But I'll never forget this case because it really stumped me for a long time because it didn't really have much blood. Now, there is a little bit of extravasated red blood cell here. There are some areas with hemorrhage, but not much. For how big this tumor is, there is very minimal hemorrhage. And I think we are so used to thinking about Kaposi sarcoma and angiosarcoma, for that matter, having a lot of erythrocytes, having a lot of blood in them, because they're vascular tumors. But some cases do not. And it's important to recognize that when we don't see the blood, sometimes our brain just skips right over thinking about vascular tumors. So one lesson that my mentor Mark Edgar taught me was that if you have a neoplasm that you're having difficulty classifying and you're having difficulty getting it to stain for anything, your usual panel is negative, don't forget to do a vascular marker. And I personally like ERG and CD31 as my two favorite vascular markers. CD34 works as well, but you have to be careful because some cases of angiosarcoma, particularly solid nodular ones or epithelioid angiosarcomas, they tend to lose expression of CD34. You have to also be careful in Kaposi sarcoma because Kaposi sarcoma can have diminished expression of CD31. The HHV8 virus actually downregulates that molecule. So ERG is actually my favorite vascular marker because it's very clean and crisp and it's very strong. ERG is ERG. ERG. So you may not have that in your laboratory, but it's a great stain. The one main caution I want to say is that it's a very sensitive marker for vascular endothelial cells, but it is not specific. It can be positive in a variety of other things, including prostate carcinoma, epithelioid sarcoma, and many others. So just remember that ERG is very sensitive but not specific. So in a hard case, I'll use all three of the vascular markers, ERG, CD31, and CD34. But here we actually don't need any of them. All we need is an HHV8 immunostain. And that's no immunostain is perfect in pathology, but HHV8 is about as close to perfect a stain as we can get. It works very, very well. And so that's, human herpes virus 8, which is the virus that drives Kaposi sarcoma, both in the setting of AIDS and HIV, and also in the setting of a classic type Kaposi, which, if I recall, that's what this case was. It was an elderly adult who did not have any history of HIV or AIDS, but elderly patients can get Kaposi sarcoma caused by HHV8, but it's thought to be due to partially due to the reduced immune system that happens in old age, and also there may be a component of being on the feet because of lymphedema type changes, and that also alters the immune system. So I kind of suspect it's a combination of those. When we see elderly adults with classic type Kaposi sarcoma, the vast majority of them that I've seen in my practice are on the feet or the lower leg. And they often are present alongside lymphedema change. And it's sometimes a debate, I guess, of whether the Kaposi sarcoma caused the lymphedema or vice versa. I have a long video that I made in collaboration with my friend Josette McMichael, aka Global Dermy, on Instagram and Twitter. And she's a wonderful dermatologist, and she presents a lot of clinical information about Kaposi, and then I discuss the path findings, and you can find that on my Kiko and YouTube channels. So just remember that not all vascular tumors have blood, and if in doubt, do some vascular markers. If you're thinking of Kaposi, do an HHV8 stain. And this was a case that I'll always remember because of how tricky it was when the erythrocytes are not present. And then finally, we'll finish up here with a last quick little case. So I showed you this one already.